Hello. Hello friends, good morning. Welcome to the 13th annual meeting of Indian Association of Cardiac Imaging. Few people will be coming in late, but the way we do it, we will start on time. So at the outset, I would like to welcome all of you to this 13th annual meeting of Indian Association of Cardiac Imaging. So at the outset, the organization started with a group of like-minded people, a small group, but now we are a growing community of more than 1,000 members across the country. We are growing and improving with every year. Last year we had certification, cardiac MR and CT certification programs. This conference we have made an app also. And this is the first time we are having the keynote address as well as the oration speech as part of the program. So I invite our president, Dr. Vijay Bhaskar Nuri sir, and Dr. Vimal Raj, our vice president, to chair the session for the keynote opening plenary session. Sir, please come. Yeah. Dr. Vimal Raj, vice president IACI, to chair the session. Yeah. Yes, yeah. So without the further ado, we will start with our opening plenary session. And I invite Dr. Vimal to introduce our keynote speaker. Yeah.
Good morning, everybody, and it gives me immense pleasure to get us kick-started with one of the superstar players for today. Dr. Vanessa Ferreira is a full-time professor in University of Oxford. She obtained her bachelor's degree from MIT and her PhD from the University of Oxford. She's a cardiologist, but we won't hold that against her. That's okay. We welcome all. And she's the Deputy Director of the Oxford Center for Cardiac MR Research. She's also the Vice Secretary Treasurer for the SCMR and is in line to succeed as the SCMR President in 2026. Her area of research and expertise is cardiac's MR parametric mapping. She's one of the persons who has been pioneer in getting mapping, T1, T2 mapping in the clinical practice. So without ado, I would like to welcome Dr. Vanessa Ferreira over to the podium.
Well, we said, hello, well, thank you so much for that kind introduction. And firstly, I'm really happy and grateful to be here in India with you all. And I want to thank the IACI for having me here from SCMR, especially President Dr. Nuri, Vice President Dr. Raj, and General Secretary Dr. Priya Chudgar, who have been taking such good care of us, and also the IACI Organizing Committee. Over the last couple of days, I have witnessed immense enthusiasm about CMR from all of you, the various practitioners in India. Your passion shines through in what you do, especially in CMR education, locally and in clinical practice. So I'm very happy to talk about the evolving role of mapping in CMR. So let me just get this started. Can you see this? Okay, very good. Right. I have been working on mapping for the last 15 years, so I'm really happy to share with you my experiences and what I've learned over the years. So CMR has undergone a number of significant developments in its maturation as a non-invasive imaging technique. As we can see here, after Cine, late gadolinium, and stress perfusion imaging, parametric mapping is regarded widely as a fourth era of CMR. T1 and T2 relaxation times of tissues, whether it's cardiac or other organs, they are quantitative MR properties. Just one moment, I don't know why it's jumping like this. Okay. They are quantitative MR properties that can be measured using MRI. So in general, parametric mapping have several properties of a good diagnostic test, including a narrow normal range, they are reproducible, and importantly, they are sensitive to detecting changes in disease. So let's go to T1 mapping. T1 mapping is a quantitative MRI technique which measures an MR property called T1 relaxation time of tissues on a pixel by pixel basis. On this T1 map here, each pixel has a T1 value of the underlying tissue, and we can code these numerical values on a color scale, such that tissues with short T1 values, like fat, will appear blue, intermediate T1 values will appear green, and long T1 values, like blood, which has a lot of water, appear red. In this way, we can begin to visualize different tissue types based on their quantitative MR properties without the need for contrast agents. So each tissue has a specific normal range at a particular field strength. Normal T1 values of the myocardium is like our body temperature. Deviation from the normal range, whether too high or too low, may indicate disease. The commonly available cardiac T1 mapping techniques have good metrological properties. So like the Schmolly technique shown here, it has a tight normal range with good reproducibility within a 2% range across multiple centers. Similarly, Molly T1 mapping techniques also show a tight normal range when you keep the method stable and consistent between centers. T1 mapping is very sensitive to detecting increased free water content in tissues, like in many disease states. So this is a study validating T1 mapping for detecting acute myocardial edema, showing superiority over traditional T2-weighted MR imaging. It has also been shown in animal models of acute myocardial infarction that both T1 and T2 mapping can be used to detect the area at risk, using fluorescent microspheres and histopathology as a gold standard. Clinically, T1 mapping can be used to detect the area at risk in acute myocardial infarction, as well as myocarditis. Here, we show that the diagnostic performance of T1 mapping, which is the red curve, is equivalent to late GAD imaging, the blue curve, except of course T1 mapping does not require gadolinium contrast agents. And it has been shown in multiple studies that T1 mapping can detect subclinical myocardial involvement in systemic diseases such as rheumatoid arthritis, lupus erythematosus, and systemic sclerosis. So far, I have shown you that acute myocardial edema and inflammation can make the T1 values go up really high. Another cardiac disease that can make T1 values go very high is cardiac amyloidosis. These are typical images of severe cardiac amyloidosis. As you can see, the cine image on the left shows a very hypertrophied left ventricle. The late gadolinium image on the right shows the typical diffuse circumferential enhancement and very dark blood pool. And a native T1 map in the middle shows diffusely high T1 values. So on the other end of the spectrum is Anderson-Fabry disease, which tends to have very low T1 values. So Anderson-Fabry disease is an X-linked disorder of alpha-galactosidase deficiency, and this results in accumulation of sphingolipids in the heart and other organs. On CMR, we see a left ventricular hypertrophy phenotype on the cine image, and the late GAD image typically shows this broad mid-wall band in the basal-infralateral wall, as you can see with the red arrow. On pathology, there is accumulation of sphingolipids in the heart, but this area of late GAD corresponds to an area of dense collagen fiber. And we can see these very clearly on the native T1 map on the late GAD image. Here, we see the fuzziness in the hypertrophied septum, and sometimes you're never really sure whether it is real or whether this is due to imaging quality. And you also see this broad mid-wall band in the basal infralateral wall where the right arrow is. Now, on the T1 map, you can easily see two populations of abnormal tissues within the LV myocardium, one with very low T1 that's coded as blue, And the area of high T1 that corresponds to the area of a scarring that has high T1 is red. So T1 mapping is not only a nice, pretty picture, but it also offers additional useful information beyond the grayscale late GAD imaging. The other disease that gives you very low T1 values is iron overload. So T1 mapping has been shown to be quite sensitive to iron content in tissues, as iron is paramagnetic and will lower T1 values. This is an example showing that mild iron overload will give you lower T2 star and T1 values, and as this becomes more severe, the T2 star and T1 values become progressively lower and lower. So T1 mapping is also useful in other types of cardiomyopathies. This study shows that in both dilated and hypertrophic cardiomyopathy, even in the segments that have a low, a normal wall thickness and without late GAD enhancement, the T1 values are still abnormal, thus again offering something beyond what the normal CMR techniques can detect. And moving on to ECV quantification. So there's a lot of interest to quantify the ECV in a variety of cardiac diseases, especially in heart failure and cardiomyopathies, because it can act as a surrogate marker for myocardial interstitial fibrosis. So the theory behind this is that the T1 shortening effect of an extracellular gadolinium contrast agent on a tissue is directly related to its tissue concentration. And the relationship between ECV in the myocardium and blood is approximated by this relationship, where lambda is the gadolinium partition coefficient. Rearranging the formula and expanding each of the terms in color, and we get the relationship at the bottom, where we would need a pre- and post-contrast T1 map, plus the hematocrit of the patient to fill in the 5 variables. Practically, what you would need to do is fill in the 5 variables in this equation. So a pre-contrast T1 map to give you the native T1 value of the myocardium and the blood, and post-contrast T1 map to give you the post-contrast T1 value of the myocardium and the LV blood, and then the hematocrit of the patient, which you would usually get from a blood sample. And when you have plugged in these 5 variables, you can estimate the ECV. And these are examples of beautiful ECV maps of the heart in different diseases, and various studies have shown that an expanded ECV carries a poorer prognosis, especially in heart failure patients. So going on to T2 mapping. And T2 mapping works along very similar principles as T1 mapping in that it measures a quantitative MR property in tissues. So you acquire T2 weighted images and you stack them and fit them into a T2 decay curve to get a T2 map, and usually these are FLASH or SSFP-based sequences. So like T1 mapping, tissues have normal T1 values, and T2 tends to go up with increased free water content in tissues. So T2 mapping is especially useful in detecting myocardial edema and inflammation in a variety of cardiac pathologies, including myocarditis, acute myocardial infarction, and Takotsubo cardiomyopathy. Now, due to their promising clinical utility, back in 2018, we updated the Lake Louise criteria for detecting myocarditis to include these mapping techniques. And we expect that these quantitative methods will replace conventional weighted imaging methods with greater sensitivity and diagnostic performance in the non-invasive evaluation of myocarditis. So specific examples of how mapping can help include the use of T1 mapping to differentiate LVH phenotypes. This shows how native T1 mapping can help differentiate between hypertrophic cardiomyopathy and Fabry's disease, both of which may look very similar on Sene and late GAD imaging, but Fabry's disease tends to have lower T1 values compared to normal as well as to HOCM. So mapping may also be useful in distinguishing athletes' hearts from patients with DCM, both of which may look dilated with lower than normal ejection fraction. This study shows that athletes tend to have normal T1, T2, and ECV values, in contrast to patients with DCM, who tend to have higher T1, T2, and ECV. So tissue characterization using mapping can help us to differentiate phenotypes. They may look similar in structure and function. Now, talking about the ever-evolving role of mapping, we have developed a new technology based on mapping to create virtual late gadolinium enhancement images. And our computer scientist, Dr. Chang Jiang, leads this work in our group. Essentially, we can create these virtual late GAD images by using just pre-contrast Cine images and pre-contrast T1 maps. And we call it virtual native enhancement, or VNE. And this is the basic concept. First, we would acquire pre-contrast images, such as Cine images and native T1 maps, which contain not only the pixel-wise color map, but it also has raw images of different T1 weighting. Then we feed them into the deep learning VNE generator. The generator would then use multiple streams of neural networks to produce image feature maps. Then all feature maps are input into a further neural network block to fuse the information from these multiple images to produce a final VNE image. We would also have acquired a real late GAD images from these patients, so the model was trained using a generative adversarial network to encourage the generator to produce images that look like the real late GAD. So overall, VNE provided significant better image quality, and that's the graph above, where we had 4 independent operators grading the image quality without knowing whether they are VNE or the real late GAD. And the VNE consistently outperforms the late gadolinium images in terms of image quality. At the bottom, the first 2 late GAD images have poor nulling and image contrast of the myocardium as compared to the VNE at the bottom. The middle 2 images were affected by motion and blurring, whereas VNE were not. And the last 2 images on the right have noise and impaired feature definition, whereas VNE showed much better image quality. So visually, VNE achieves significant better image quality. Now, what about the quantification of the late GAD lesions? VNE also correlated strongly with conventional late GAD in quantifying hyperintensity to intermediate intensity lesions in hypertrophic cardiomyopathy using various image analysis thresholds for comparisons. So that was the initial validation of the VNE technology in patients with HOCM. We then moved on to develop VNE for detecting scars in chronic myocardial infarctions without the need for gadolinium contrast agents. In our results, here is a patient who has a chronic myocardial infarction downstream from the left anterior descending artery. There are 3 short axis images, and VNE revealed the infarction on all slices in high agreement with the real late GAD. These are corresponding transmurality plots on the right, where red indicates low viability and green indicates likely viability, using the 50% thickness cutoff between the 2 shades of colors. And we see a very clear transmural LAD infarction on both the VNE and the late GAD. Similarly, in another patient with a transmural infarction in the left circumflex territory, the VNE detected a transmural MI matching with the conventional late GAD. Now, what about infarctions in multiple territories? And here is another patient where VNE revealed 2 infarctions, one in the septum and one in the inferior block, confirmed on the LGE images. And again, we see a high agreement between the 2 methods on the transmurality plots. So VNE correlated strongly with late GAD in infarct size and in quantifying the average transmurality of the infarcted segments for each patient. As proof of principle validation, we also tested VNE in a pig model of chronic myocardial infarction with CMR and histopathology data from our collaborator Rohan Damakumar. VNE revealed a clear LAD infarction in these 2 test cases in high agreement with the ex vivo slices and histological staining. To test the VNE technology in real-world clinical workflow, Chang had implemented the deep learning models into a pipeline to produce VNE images on the fly during scanning. So here is our first test in our scanner room on a patient who was referred for viability assessment. We took the pre-contrast Cine images and native T1 maps as soon as they were acquired and produced the VNE images before the late-GAD images were acquired while the patient was still in the scanner. So here are the VNE images showing a clear infarct scar in the anterior wall and anterior septum. And there, they were then confirmed on the real LGE images. And in this patient, the VNE showed high agreement with the late GAD in the location and extent of the infarction. So here you can see on the late GAD images where the yellow arrows are pointing, there are breathing artifacts on the late GAD because the patient was getting tired by the end of the scan. In comparison, the late GAD has overall better image quality, partly also because it is acquired very early on during the scan when the patient had only just gotten into the scanner. So parametric mapping is already widely used in many clinical centers worldwide for clinical applications. And beyond Cine and late GAD, mapping has been shown to aid advanced tissue characterization in a number of studies, especially over the past decade. They may be especially useful in detecting changes in edema and myocardial inflammation, such as in acute myocardial injury or suspected myocarditis. Differentiation of LVH phenotypes, such as hypertensive heart disease, HOCM, cardiac amyloidosis, Fabry's disease, and athlete's heart. Non-ischemic heart failure, so without late GAD and evidence of obstructive coronary disease, and assessment of iron overload. These MR signals like T1 and T2 correlate to histopathology in a range of diseases, including the presence of acute myocardial necrosis, focal fibrosis, edema and inflammation, and also expanded interstitial space, whether this is due to amyloid, infiltration, or interstitial fibrosis. But remember that these imaging signals like T1 and T2, they are nonspecific. And we also need to interpret them within the clinical context of an individual patient. And in the ever-evolving role of mapping and CMR, it is now possible to use native mapping to create virtual late GAD images using AI and machine learning. So I'll take questions in a moment, but let me share with you that SCMR is very happy to offer members from India significantly discounted membership rates of only $25 for full members and only $10 for the technologists. I heard feedback from you that SCMR online education content have been very useful, and SCMR membership provides you access to those via the online portal. And other discounts, would be to the annual scientific sessions, to publishing in JCMR, level 1 workshops, and also discounts, when you need a letter of verification for your CMR training. You can download free online resources throughout the website, and you're also eligible to receive SCMR awards. So, you're also eligible for the FSCMR, the Fellow of SCMR designation, and you can get discount to job postings and other benefits. So do check it out. And here is the SCMR website online learning material. You can access these when you're a member. Many are free or with significant discounts. And finally, the upcoming CMR 2024 in London. This is a joint conference between SCMR, IACI, and also the European Society of Cardiovascular Radiology, and promises an excellent education program. And so thank you. I'm happy to take questions.
Thank you very much, Vanessa. I think that was really great, and thank you for coming over and educating us in there. Because we have a few minutes, if I could start off with a simple question that we all face many a times. We are seeing patients refer to us for suspected cardiomyopathy or borderline LV systolic functions. There is no late gadolinium enhancement, but the T1 mapping is elevated in that scenario where the ECV may or may not be elevated. We presume this means diffuse interstitial fibrosis, and the clinicians ask us what is the significance of this? How do you answer to that?
Yeah, that's a really good question, and something I do all the time as well. When somebody is referred to, oh, the echo shows that LVEF is 25%, looks like a DCM. Can you figure out what the etiology of the cardiomyopathy is? So when I get a patient like that, we would obviously do the CINAs and the LADGAD, but we would include T1 and T2 mapping. And sometimes you find that the T1 and the T2 mapping are elevated. And in those cases, now, because T1 and T2 elevation just means there's extra water in there for some reason. And one of the potentially reversible causes of DCM or cardiomyopathy is myocardial inflammation or some sort of undiagnosed inflammatory etiology. So I would suggest to them that consider ruling out inflammatory etiologies of the DCM, because the DCM, as you all know, is not a diagnosis. It's just a phenotype description, dilated cardiomyopathy. Something causes the DCM, and you want to look for reversible causes before you label it as idiopathic, maybe a genetic cause or something. So if it's elevated, I would say rule out myocardial inflammation, because that is something you might be able to do something about. It could be interstitial fibrosis. You don't know, because we are not histology. We can only speculate. But in general, high T1 is not specific. It just means that there's some extra water for some reason, and that reason could be edema, it could be inflammation, but it also can be chronic fibrosis, especially if you don't see a focal scar, it may be interstitial fibrosis. Sometimes the degree of T1 elevation gives you a clue. If you have interstitial fibrosis, like the papers you see in hypertensive heart disease, where the area of hypertrophy will have high T1, the degree of elevation is not that much. It's a little bit above normal, but it's not sky high. So if you see sky high T1 elevation, it may be more suggestive of some sort of inflammatory etiology. Dr. Nori?
I'll ask one question, ma'am. I have this doubt I wanted to ask you for a long time. In many of your papers, you have mentioned that there are so many variables in acquisition, and also so many conditions like chronic diabetic, metabolic syndrome, hypertension, aortic stenosis, some drugs. There are many conditions which alter the T1 map values in the LV myocardium. So if I am doing a T1 mapping, should I beforehand know that there's no aortic stenosis, there's no metabolic syndrome, he's not a chronic diabetic? Do you have to take all those into consideration before giving the T1 map value? Because they can also influence the T1 map values in a given setting.
Yeah, I don't think I would necessarily screen out, patients that, oh, you can't have AS or anything before you do. I think we just need to recognize that if you do the mapping in those patients, there may be multiple reasons why the T1 is elevated. And it could be that you are unable to tease out what it might be due to. So if you have a patient with severe aortic stenosis and you do a native T1 map, it's going to be elevated. And if you say, well, why is it elevated? It's going to be a combination of, because they have resting coronary vasodilation, that gives you extra water and myocardial blood volume in there. And it also could be that they have interstitial fibrosis from the chronic AS. So there will be multiple reasons why that person has elevated T1 value, depending on their clinical condition.
So according to you, it's a non-specific entity, but there is elevated T1 map values which indicate interstitial expansion. It could not be necessarily fibrosis. It could be edema or water fluid overload also.
That's correct, yeah.
So how am I going to report it now in such a situation? I'm going to call it as interstitial expansion or fibrosis? Yeah,
so I think sometimes the referrers think that CMR can act like histopathology. We can tell them exactly what it is, but in fact we cannot. So in cases like this where I would find, okay, there's an elevated T1, I would explain to them that, okay, there's high T1, it is non-specific, and it could be due to these, and that, and the typical radiology thing, clinical correlation required, right?
Yeah. Thank you so much, ma'am.
Thank you, Dr. Vanessa. And all dear friends, these are the people who have made guidelines. times. We have read papers and they are here to teach us about parametric mapping. So though because of the time constraint, we cannot take more questions, but we will definitely, she's always there with us for 2 days. So during the break, and very helpful, and she will be happy to help so that we can also move on to fourth generation of CMR and use parametric mapping.
Yeah, thank you,
May I
Priya.
invite Dr. Rajesh and Dr. Vimal for felicitation of Dr. Vanessa.
Oh, I see. I see, okay.